Good evening, sir.
Good evening. Good evening, Prasanna.
Sona, sir, good evening.
Madam, good evening. Welcome.
Yeah.
Welcome.
Dakshani, good evening.
Ma'am, good evening, ma'am.
Good evening.
Good evening, Dakshani.
Good evening, sir. Good evening.
Good evening, ma'am.
Sir, good evening, sir.
Tarun, ஒரே ஒரு வாட்டி ஷேர் பண்ணி பாத்துறீங்களா உங்க ஸ்லைட்ஸ் ஷேர் ஆகுதான்ட்டு?
Yes, sir.
Sir, good evening.
Good evening, Daksh. Welcome.
Full screen போட்டுங்க.
Yes, sir.
Okay. Unshare பண்ணீங்க.
Start பண்ணிடலாம், Prasanna.
We'll wait for a minute, sir. Few people are joining.
Prasanna, initial introduction start from it will be 3-4 minutes. I don't.
Sure, sir. So, with this, I welcome you all for the 7th edition. So, this is a Gastro edition, 7th edition of virtual Gurukulam. So, we even shared the first 6 editions as a single PDF with the YouTube link, and the response was very nice. So, today we have 2 eminent people. Senior Professor Dr. B. Sumati Madam is there, and Dr. Dakshani, Professor of Pediatrics from Chengalpet, is also there. I welcome you all, Madam. And to present the case, we have Dr. Tarun. Dr. Tarun is from Rela Hospital. Rela Hospital is known for gastro cases. So we decided to give Rela Hospital this time chance. So let me formally welcome Professor Dr. Sumati Madam, Professor and Head of Medical Gastroenterology, Government Stanley Medical College. She is also the national faculty in pediatric gastroenterology and Indian Society of Gastroenterology. She is a past EB member of ISPEGAN, and she is also an editorial board member of IJPP previously. And she's one of the governing council member previously of Tamil Nadu chapter of ISG and editorial member of APGH. So one of the eminent pediatric gastroenterologists in the city, hardened teacher and reputed gastroenterologist. I welcome you, madam. And then I welcome Dr. Thank you, madam. And then I welcome Dr. Dakshani. Dr. Dakshani is our IAP stalwart. She's MD Pediatrics and PG Diploma in Epidemiology. Currently working as Associate Professor in Pediatrics in Chengalpet Medical College. She is also the State Academic Coordinator, Tamil Nadu State Academic Coordinator and Treasurer of Tamil Nadu State Medical Education Chapter. She was Treasurer of IAP State Chapter. She was also editor of IAP State Chapter previously from 2017 to 2022. And she was also editor for the Chennai City branch. So from 2016 to 2021, and then she moved to the state. She was also an EB member of Tamil Nadu AHA 2024. She is now currently one of the editorial board members of the IJPP. So past board member Sumati madam and the current board member Dakshani madam, both of them are there. She was one of the recipient of Balagopala Raju Active Pediatrician Award and the recent Yuva from the National President. So with this, I think we have a wonderful session ahead. I'm looking forward to the session. Som Sundaram sir, a few words from.
Yeah. So good evening, the eminent faculty, Sumati madam and Dakshani. Sumati madam is well known as a pediatric gastroenterologist of the district and town, and she was ma'am was actually with me in was my senior in the T7 ward, ma'am. So we have learned a lot from ma'am in gastroenterology, and Dakshani, you all know she's good in all these specialties. She can talk a lot in nutrition, gastro, immunization. So we have two eminent faculty, and Prasanna is there to coordinate. So yes, he's doing a good job for the past 7 sessions, and hope this session will also. The only thing we will be missing Dr. SBS sir because of his family commitments. He was there with us for the past 6 sessions, and we will be having back for the next session from the next session onwards. And hope this session will also be a great learning experience for the postgraduates and the practitioners who have joined on time on this Zoom platform. Over to Prasanna to take over the session. Thank you.
Madam, a few words from you, madam.
Yeah, nice. Thank you, one and all, for a nice introduction. I feel really honored to be with all the associates of IAP, whom I know very well. So I think we are not wasting much of time for the students. I think Prasanna can take over and present the case. We'll follow it, and I think we can take a discussion one by one. All the best, Prasanna. Yeah, take over the case. Yeah.
So 1 minute, sir. Thanks to IAP, Som sir and Prasanna sir for the opportunity. And above all the attributes, I'm Sumati madam's student, and I'm so happy and glad that I'm able to share the stage with her today. Thank you, ma'am.
Thank you, Dakshani. Thank you, Soms. Thank you, Dr. Prasanna. Yeah.
Tarun, can you start?
Yes, sir.
You can start sharing.
Slides visible, sir.
Yes, yes.
Thank you, IAPCCB, for giving me this opportunity. So we'll start with the case. So this is a baby V, a 2 months old male child, firstborn of second degree consanguineous marriage. brought by mother from Dindigul, whose reliability is good, with chief complaints of yellowish discoloration of the eye for the past 2 months, high colored urine for the past 1.5 months, and abdominal distension for the past 2 weeks. Since the symptoms started from neonatal period, I would like to start with antenatal history. So mother's age was 27 at the time of conception. It was a spontaneous conception, registered and immunized. Iron and folic acid supplements were taken. There was no history of fever with rash or lymphadenopathy in the first trimester. There was no history of pregnancy-induced hypertension, gestational diabetes mellitus or UTI. There was no history of pruritus or jaundice in the third trimester. And there was no history of foul-smelling liquor or bleeding PV. All the antenatal scans were said to be normal. Coming to the natal history, baby was born term at 37 weeks via normal vaginal delivery with a birth weight of 2.7 kg. Baby cried at birth, no history of NICU stay. Baby was started on breastfeeds within first hour of life, and baby has passed urine and meconium within 24 hours of life. Coming to the postnatal history, baby was noted to have yellowish discoloration of eyes starting from the day 2 of life, for which baby has received phototherapy for 2 days and then discharged on day 4 of life. However, the yellowish discoloration of eyes was persisting, but the mother was reassured that it will take time to disappear. But it was gradually progressive and involving the whole body. One mother also noticed dark yellow colored urine staining the diaper starting from the second week of life. On further probing, mother said that baby was also passing pale colored stools from the second week of life. Initially, it was slightly pigmented and later became persistently pale. And there was also issue of abdominal distension noted for the past 2 weeks, which was insidious in onset and progressive in nature, more in the upper abdomen. There was no history of persistent vomiting, lethargy, or seizures. There was no history of constipation or bulky stools. There was no history of recurrent respiratory tract infection. There was no history of bleeding from injection sites. There was no history of excessive cry, irritability, or feeding refusal. There was no history of hematemesis or melena. For the above-mentioned complaints, child was evaluated in a private hospital in Dindigul, and parents were informed that baby has some problem in liver leading to this jaundice and needs further evaluations. Hence, baby was referred here for further management.
Prasanna, can I just go back? Can we discuss the history, doctor?
Yes,
Somasundaram, Dr. Prasanna, Dakshayani.
Yes,
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 ma'am.
madam.
I thought like we can
Yeah.
do it.
Yeah.
And
Just
then
go back to the first slide. First slide. So what is the importance of the age of the child in this case?
2 months old male child.
So how can is it better to give in days? 2 months is equal to 60 days. Why days
60.
is very important in neonatal cholestasis, doctor?
In surgical cases such as biliary atresia, yearly
Yeah.
surgery as a good
Yeah,
protocol.
60 days is a cutoff. So 60 days, any surgery of biliary atresia before 60 days, the patterns of bile flow will be better. So that always tell in days whenever present a case of NCS early infancy. That's one thing. And as mentioned, you mentioned about the degree of consanguineous marriage, whatever it is, to look for any other inborn errors of metabolism. Okay. So always better to tell. Then what is the importance of a yellowish discoloration of eyes and urine? Do you think it is a physiological jaundice in your case?
No, ma'am. Because
Yeah.
of high colored urine.
Very good. Why high colored urine is always pathological?
High colored urine denotes a conjugated bilirubin.
Yeah, bilirubin, which is always water soluble and lipid insoluble, whereas unconjugated is always water insoluble. So you ask the mother, high colored urine stain the diaper. That is very important. Okay, so you ask the mother whether the diaper is stained. Okay, so that indicates a cholestatic jaundice, and a cholestatic jaundice is always pathological. Okay, very good. Yeah.
Dr.
Tarun? Yeah, tell me. Tell me, Dakshan, yeah.
Dr. Tarun,
Yes, ma'am.
are you able to hear me? Like you
Yes,
said,
ma'am.
the child had jaundice, the mother noticed jaundice since the second day of life. If a baby presents with jaundice at day 2 of life, what would you initially think of? Conjugated hyperbilirubinemia or unconjugated?
I'll usually think of unconjugated hyperbilirubinemia on the day 2 of life.
So how best you can ask the mother or the doctor who has taken care of the child in the newborn period, immediate newborn period?
Why is it important to initially differentiate between your cholestatic jaundice and unconjugated hyperbilirubinemia? Why is it essential, both in the
Uncon-
treatment part?
Unconjugated can be a physiological jaundice, ma'am.
How
It
can you get physical jaundice on day 2?
Usually, when is the onset? When does it peak? When does it plateau and
peak
disappear?
by 3 to
Physiological
5
jaundice.
days in
Yeah.
term babies, ma'am.
So it's always so ask the duration of onset. Also ask the mother, no, the urine color. Okay,
Correct.
sometimes urine is yellow, sign the diaper on day 1 also. You can even think of a cholestatic jaundice in utero onset of biliary atresia also. So there are few conditions. So high colored urine is very important in a case and the onset of jaundice. Okay, very good. Yeah. Dakshan, yes. Any question? And phototherapy is contraindicated in cholestatic jaundice, whereas it is no, it is available treatment. Whatever you always give phototherapy in unconjugated hyperbilirubinemia in a newborn. So you have to differentiate all the more even day 1 or day 2 the onset of jaundice with high colored urine. You should see the urine color which is staying in the diaper if it is given by the mother, or you should examine. Okay. And IAP has given even a urine color card test, neonatal card test for urine color now. I think the newborn nursery can have even that urine color card test. We can integrate with the stool color. You can pick up biliary atresia even at the earliest. Yeah. What is the importance of abdominal distension in your case, Dr. Tarun?
Here, abdominal distension started little late, ma'am. It is more towards the upper abdomen, so I am thinking of organomegaly.
Yeah, very good. Organomegaly. You will not get organomegaly in physiological jaundice.
Yes.
It's always no physiological jaundice. You never get organomegaly. Okay, so it's always here in your case. It is a pathological jaundice because very good history of jaundice with high urine stain in the diaper with abdominal distension indicating a organomegaly. If it is uniform distension, can you think of organ as something else?
Can you go to the next slide, Dr. Tarun?
In
Yeah.
case of uniform distension, I would like to think in terms of
Fluid.
gas and fluid, ma'am.
Gas or a fluid. Yeah. Okay,
Fluid.
proceed. So mother's age, what is the importance of mother's age in your case?
Ma'am, increased mother's age can be a risk factor for syndromes associated
Very
cholestasis
good.
such as
Very
Down
good.
syndrome.
Very good.
Yeah.
Yeah. Then you asked about your history of PAH and IUI infections the first trimester. Very good. And also prurate. What is the importance of pruritus in the mother?
It can be associated with a PFIC and progressive
Yeah.
And
Intrahepatic cholestasis of pregnancy, the mother can be associated with PFIC also. Very good. And
what
jaundice.
did you have in mind when you
Ah.
asked for fever with the rash and lymphadenopathy?
intrauterine infections, ma'am.
Like
Like
what?
yearly infections like rubella.
Rubella, like you can add on fever, rash, post-auricular
Post-auricular
lymphadenopathy, tender
lymphadenopathy.
lymphadenopathy, and joint pain in the mother. That would be very severe with rubella. Okay. No history of foul smelling liquor?
For like a PROM causing increased risk of infection during the time of delivery.
So neonatal sepsis is very good. Yeah.
Neonatal sepsis.
What is the importance of antenatal scans? You said it is normal. Anything can give a clue in suppose can an antenatal scan be useful in your case sometimes?
Yes, ma'am. In cases of like choledochal cyst, we can find and like biliary atresia with the splenic
Very
malformation,
good.
we can see.
Very good.
So, very good. Very good. Yeah, proceed. Next slide. So what is the importance you're given is a term child, birth weight of 2.7 kg, that adds your, like one of the contributing factor to your diagnosis of biliary atresia, whatever in your case. And what is the importance of your tried immunity after birth? How that is important in a cholestatic baby?
In asphyxia and all, we can get
Very
a
good.
ischemic hepatitis.
Very good. Yeah. Number 2.
Number 2, the child can go into NICU and there will be a prolonged TPN or
very good. And
infection.
asphyxia babies are also prone for infections, neonatal sepsis. Very good. Excellent. And you're given start and breastfeeds within 1 hour of life. How breastfeed is very important in cholestatic jaundice? Dakshan, you can also add. Yeah.
Nice.
Breastfeed usually indicates the wellness of the baby, ma'am.
Very
If
good.
the,
Yeah.
if the baby can
Okay.
suck
Why
well
is
after
this,
the
I mean, a term baby and a birth weight of appropriate birth weight, why is it important in this case?
In cases such as like intrauterine infections, there can be a prematurity, microcephaly.
Would you relate it to
IUD.
the cause of neonatal cholestasis? Like, would it give clues? A term baby born with a normal birth weight and an IUGR baby which is born with a low birth weight. Would it give you any clue regarding the etiology of this condition?
Yes, ma'am. In neonatal hepatitis, due to intrauterine infections and all, babies' weight will be usually low, ma'am, like IUGR babies, preterm babies. But in case of surgical causes like obstructive causes, cold local cyst and biliary atresia, the baby will be with normal birth weight and term babies.
Yeah. And breastfeeds, yeah. And breastfeed, you said, it indicates wellness of the child. The child is very sick, the child will not be put on breastfeeds. They can be on TP and whatever it is, even IV feeds, whatever it is. Second, no, galactosemia, breast milk is contraindicated. And also prelactal feeds, if given to the baby, they are prone for infections. Okay, very good, yeah.
Fast meconium within 24 hours of life. You think this is relevant?
Yes, ma'am. In babies with congenital hypothyroidism or cystic fibrosis, there can be delayed passage of meconium, which can give a clue to this etiology.
Yeah. Okay.
Okay.
Yeah, next. Okay, so there you have to concentrate the urine color because the baby was put on phototherapy. Make sure whether it is unconjugated, conjugated from the history, and by your simple bilirubin fractionation will give a clue. Okay, so what do you mean by cholestatic jaundice? Now, after discussing the case, when can you get cholestatic jaundice in general? Tarun?
Whenever there is a defect in either secretion or
Yeah.
excretion of the bile,
So
starting
defect in
from
bile formation, very good. Bile formation or bile secretion at the canaliculator level, transport or even obstruction of the bile flow. So can be hepatocellular versus your obstructive cholestasis. Very good. Yeah, very good. Yeah.
Tarun, according to your history, you have given a list of history. Like, what do you think were the reasons for the delay in the diagnosis of this condition? Like, the child had jaundice.
Yes.
Why do you think the child presented at 60 days, though the child had symptoms from day 2? Usually, what will be the norm, or why is it diagnosed late?
Usually, not seeing the direct conjugated levels, that can be one of the reasons, ma'am.
The mother has been reassured, right?
Yes, ma'am.
So, yeah, because most of the time we think child presents with jaundice on day 2 of life, it is usually physiological. Or it could be breastfeeding jaundice or breast milk jaundice because the child feeds well, looks well, and has been apparently okay, a term baby, normal birth weight. So, and the child had pale stools, you will always reassure the baby is on breast milk, so the child would pass pale stools. And the urine also, the child is getting some drops, medication. So that is why it usually gets misled and leads to a delay in the diagnosis.
So you should always ask the mother to come for a follow-up at 14 days of life, even if it's unconjugated, whether it has in a term set to disappear by 7 to 10 days. So always the 14th day, you should always examine the baby, look for the color of the sclera, the body, as well as the urine color. It's very, very important. Okay. Second, can you get a cholestatic jaundice in a case of, suppose the case is the indirect hyperbilirubinemia initially, now present in cholestatic jaundice, what are the possibilities? Can you think? Attribute sometimes.
Biliary atresia can be an on-board, for example.
Suppose there is excessive hemolysis also, you can have insufficient bile syndrome. Yeah. So initially unconjugated due to whatever it is, if not in this case, ABO or RH incompatibility, when they have excessive hemolysis can go for your cholestatic when they have insufficient bile syndrome. So any babies present with jaundice, you should always tell the mother to come for a follow-up. Okay, you should tell the mother the urine color, to know the stool color, the activity of the baby, the feeding, all those things. And as a pediatrician, you should examine the baby by 14th day. Okay, from the newborn nursery, they should always be told to come for a follow. Very good. Yeah, next slide. Yeah. Next slide. Yeah. So very good. You mentioned what is
Why
the
is
importance
this history of persistent vomiting important, Dr. Tarun?
In cases of metabolic syndrome such as metabolic disease such as galactosemia, there can be a persistent vomiting
Why?
lethargy. A baby will not be able to tolerate the heat. Feed
Okay.
intolerance can be there.
What is the importance of seizures in your case?
Seizures, it can be due to either hypoglycemia, secondary to galactosemia,
Very
or
good.
it can be due to intracranial bleed due to
Very good.
Very good.
coagulopathy.
Very good. Okay, sometimes sepsis, meningitis can also have seizures. So it can be due to a metabolic derangements or due to IC bleed secondary to coagulopathy, or sometimes is a part of infection of the brain as well. Very good. Yeah.
History of constipation, why is this important?
Again, in
And bulky
hypothyroidism,
stools also.
constipation can be seen in hypothyroidism and cystic fibrosis, ma'am. And bulky stools, I
Yeah,
wanted to
bulky
rule out.
stools, it takes a lot, no, later time usually in general, however, okay. And the recurrent respiratory tract infection, due to cystic fibrosis. And very important, when they come for, immunization, on the 6th week, you should always ask, is there any bleeding from the IM site? So that history is very important. Yeah.
The child received pentavalent at day 45 of life.
They have missed the dose.
Yes.
No, ma'am. They have not received that dose.
Why?
Actually, 45 days they have not visited the hospital, ma'am. At around 50 days only they have visited the hospital. After noticing the abdominal distension only they have visited the hospital, ma'am.
Okay.
And excessive cry,
But
irritability.
how did you ask for history of bleeding from injection site? Usually the injection site that we mean is post-vaccination bleed, right?
Yes, ma'am. Initial vaccines only they have given, ma'am, like birth vaccine, hepatitis B, which was given on the before discharge.
Okay. What else would you give at birth? Apart from
Uh,
hepatitis B?
Hepatitis B, BCG, and oral polio.
Any other injection it is
Yeah.
found mandatory to be given at birth pertaining to this case?
Anything you can think about
Same
that.
site, same site, other limb. You give hepatitis B in one limb and this injection in the other limb. What is mandatory, Tarun? This case? What else would you give at birth?
Vitamin K, ma'am.
Very good. Which form of vitamin K?
Vitamin K,
How many forms are there?
3 forms.
Yeah. Which would you give at birth? Which is recommended?
2, ma'am.
No.
Which form?
You have to give vitamin K1.
Okay.
Piloquin. Okay.
Then you should tell the mother to the staff nurse who's putting the injection to apply pressure at this site, because if it is a cholestatic jaundice. And one other, suppose the mother had jaundice during the last trimester, if she is hepatitis B positive, what other injection the child would have been exposed to prevent transmission? They'll also ask sometimes.
Immunoglobulin and
Hepatitis B immunoglobulin. So any other injection in cholestatic, the mother is jaundice during pregnancy, especially during last trimester, they also ask the mother whether she has received any antiviral drug also. Okay. Rarely we can get this case. It's very good. And what is the importance of excessive cry and irritability in a child?
In excessive cry and irritability can be due to IC bleed also, ma'am.
Very good. Suppose the child is coming at 4th month or 5th month with excessive cry, irritability, what else you think of other than IC bleed?
Pruritus, I would.
Very good.
Okay, very good. Yeah. No, it's just, I think very good. No GFD. Proceed. I think the time is for 1 hour, no? Yeah, proceed.
Yes, ma'am.
Somasundaram and Dr. Prasanna, if anything it's very slow, you can just let us know. Oh, yeah. Okay.
All good, madam.
Yeah.
Tarun, nalla பண்றீங்க நீங்க.
Very good. Very good. Yeah. You're answering also. So next slide you can go.
Yeah, you can proceed.
Coming to the developmental history, child reacts to sound, social smile is present and fixes and follows the object. Immunization, BCG, hepatitis B, and oral polio, both dose was given.
You add on vitamin K also.
Yeah.
And this developmental history of fixing and following light would be better.
Yeah.
Because it's only 2 months old. So what does this rule out? Pertaining to this case, a child is able to focus you have what
Visual.
reflex would you look for at birth in the eye?
See, in other
Sorry,
words, how eye examination is very important in your case. That's what she's asking you.
we can see cataract and all in
Very.
electroscopy.
And one other history, the umbilical cord also can ask the mother whether any umbilical cord, what was the day it fell down? Was there any discharge or foul smelling discharge, any bleeding? Sometimes they can just come with bleeding from the umbilical stump as a part of coagulopathy. You should always keep two important things. One is always a cholestatic jaundice, another one is always a factor 13 deficiency. Okay. So apart from IM site injection bleed, you also ask the mother, was there any bleeding from the umbilical stump when it fell down? Yeah, very good. Yeah. Next.
Coming to nutrition, child has been exclusively breastfed on demand feeds 8 to 9 times a day, and daily supplements of vitamin D drops were given. Coming
Why
to
do
the
you
family,
think breastfeeds are the best feeds for a baby with cholestasis?
breastfeeds are usually pre-emulsified
Yeah.
breast milk.
So it
So it
contains
will be easy.
Breastfeeds, the fats in breast milk are pre-emulsified, so they do not require your bile salts and acids for absorption. Good.
Absorption.
Very good. Yeah, families too you have mentioned. Yeah, proceed. Next slide.
Socioeconomic history. Family lives in a Pakka house, belongs to lower middle class according to the modified Kusami scale.
Yeah.
Coming to the summary, this is a 2 months old male, 60 days old male child, born as a term baby with a normal birth weight and a well-thriving child presenting with a jaundice, high-colored urine and pale-colored stools with
Eye color
upper
urine, stain in the diaper with persistent or intermittent pale stools. That word is very important. So jaundice, eye color urine, always add the word stain in the diaper, which indicates it's a dark bilirubin. Number two, the persistently pale colored stools. Why that is important?
because persistently pale-colored stools usually indicates an obstruction.
Yeah, you can. Yeah, very good. You can even get pale stools in intrahepatic cholestasis. It can be transient. So persistent pale colored or white colored or chalky white colored stools always indicate obstructive jaundice unless put otherwise. Okay, Tarun. So you put that adjective. High colored urine stain the diaper with persistently pale colored stools with upper abdominal distension, probably due to organomegaly presenting from the 60th day of life. I would like to think of the diagnosis of a cholestatic jaundice, probably
Obstructive cause.
obstructive causes. Among the obstructive, what are the causes you think of?
Surgical or medical cause you're thinking?
Mostly I'm thinking of surgical
So
cause
among the
because of
surgical names and surgical conditions it can present with cholestatic jaundice, one is biliary atresia, number two.
biliary choledochal cyst can be
Very good.
Very good.
Sometimes, no, strictures of the common bile duct. Okay, CBD, though it is very, very rare. Okay, CBD obstruction due to even stones, which is very rare, and spontaneous perforation of the bile duct. Okay, very good. Yeah.
And also, I would like to think in terms of other diseases such as progressive familial intrahepatic cholestasis, Alagille syndrome, bile acid synthesis defect, and even cystic fibrosis.
Will you not think of any sepsis in a child? Shall not work for sepsis.
I have not
No, the
listed
history
sepsis
is
here.
not there.
What made you rule out sepsis in the even in the differential diagnosis?
Child is
Water is
well.
okay.
Child
Why
is
did you
well.
think of biliary atresia in the first place in this child?
Here it is important to first rule out biliary atresia because the child is already 60 days old with persistently pale colored stools.
Okay.
So my first differential
So
is
this is
biliary.
a non-sick infant, a term baby of ideal birth weight, a non-sick
Yes,
infant, no other features of sepsis to suggest. So, and of course, as you said, biliary atresia operating, this case is an emergency. So you have placed it first. Okay. So
Why should we identify biliary atresia at the earliest, Dr. Tarun? What is the other name for biliary atresia? Progressive obliterative cholangiopathy. It's a dynamic disease. You miss the bus. There'll be dynamic changes. There'll be going for cirrhosis. Child can come with end-stage liver disease even by 4 months. So it is always better to identify. So it's a progressive obstructive obliterative cholangiopathy. Okay. Okay.
yeah, go ahead.
Yeah. Next slide.
Coming to the general examination, child is alert, lying comfortably on mother's lap. Icterus present. There was no pallor, cyanosis, lymphadenopathy, or edema noted. Heart rate was 124 per minute with a pulse of regular pulse, a BP of 80-50 mmHg, respiratory rate of 34 per minute, SpO2 of 99%, and temperature was 36.8 degrees Celsius.
Here they'll ask about the various methods of measuring BP in a newborn or young infant. Okay, read about that. What are the different methods? How will you, different size, no, cup size, all these things as a pediatrician you should know. Okay, proceed. Very good.
What
Yeah.
was the thermometer that you used?
A digital thermometer.
Okay. What is the inference on an anthropometry in your neonate, in your young infant?
For this infant, the anthropometry was normal, ma'am. Weight for
So
age
child
was
is a well-thriving child. Okay, very
well-thriving
good.
child.
Yeah. Okay.
Weight of
Next.
4.8 kg with lying between 15th and 58th percentile, and height of 56.5 centimeter lying between 15th and 58th centile, and weight for length also lying between 50th and 15th and 50th centile. Head circumference of 40 centimeter, which was between 50th and 85th centile.
Very good.
So,
So head
anthropometry.
measurement is also very important because there are certain conditions where you have microcephaly and cholestatic, like IU infections. Okay. Some macrocephaly, Down syndrome, hypothyroidism, you can have a large head, patent PF. So head examination is very important. I think you're going to know that. Anyway, okay. Carry on.
Coming to the general examination, anterior fontanel was 3 into 3 centimeter, flat and pulsatile. PF was open, admitting a tip of little finger. There was no dysmorphic features, no
Tarun, if you
cataract.
can stop. Why is this anterior fontanel important?
Anterior fontanel, there is delayed closure and wide anterior fontanel in hypothyroidism and due to rickets.
Intra
Vitamin D
infections
deficiency.
also sometimes you can get delayed or even premature closure. Then
Vitamin D deficiency
very good.
causing rickets.
Downs.
Downs.
Okay, yeah.
Okay.
Dysmorphic facies, give some examples.
And Alagili syndrome.
Very good, Alagili.
Very
Number
good.
2, yeah, number 2.
Down syndrome.
Very good. Number 3.
Hypothyroidism can.
Then any other added congenital anomalies? Like
Any other
what is, if you see a midline defect in a child with cholestasis, what do you think? Cleft lip, palate.
Panhypopituitarism.
Very good, very good.
Very good.
Suppose there is arthrogryposis. What is the arth syndrome?
Renal.
Okay, they'll ask sometimes. So, IUI infections, Down syndrome, hypothyroid, and Alagili. These are the common conditions you should keep in your mind when you're talking about dysmorphic facies. All the other conditions are very rare. So, you can just write for theory, but in a practical examination, whatever they ask in clinics, common things are always common. Okay, very good. Yeah. Ecchymosis, petechiae accepted. Any other skin manifestations would you like to comment?
They can have blueberry muffin rashes.
Very good, very good. What is blueberry muffin?
It is due to the extramedullary hematopoiesis, that is dermal hematopoiesis happening.
Very good. Yeah. Where do you get it?
In intrauterine infections.
Very good. Very good. Yeah.
Any other conditions you can get blueberry muffin spots? What are those indicative blueberry muffin spots over the skin? What are they indicative of?
Extramedullary hematopoiesis is happening.
Dermal hematopoiesis.
Dermal
So,
erythropoiesis.
hemolysis, bone marrow failure syndromes you can get additionally. So this no cataract you mentioned. Tell me some conditions wherein you can get a cataract causes some etiologies for cholestasis wherein you can have a cataract in children.
Then congenital rubella. Then Downs. Sometimes even hypothyroid. Okay. Yeah.
No signs of vitamin deficiency. It's an umbrella. What all have you looked for?
Ma'am, I look for.
Can you enumerate all the?
In vitamin A deficiency, it is very early for the child to manifest.
Why early?
Why?
Usually, it will take 3 to 5 months to.
Mother's milk will contain.
Mother's milk is milk.
And there will be storage. Where is vitamin A storage stored in the body?
Liver.
Where? Liver, which cell? What is the cell called? You are answering very well. Very good answer. Yeah, erythrocyte. Very good. Yeah.
Where does it?
Hmm. Okay. Oral cavity should examine for anemia. Then
D, how does it manifest? Vitamin D deficiency.
Craniotabes and wide anterior fontanel, widening of wrists and this thing, racket rosary.
Rackety rosary, okay.
Yeah.
So child can also have a Harrison sulcus. K,
K usually it will manifest with bleeding.
the
Bleeding
most common vitamin deficiency you see is vitamin K. They come with bleeding. Okay. In utero
vitamin
onset,
A
when they
deficiency.
yeah, in utero onset of we have biliary atresia, severe vitamin D deficiency. Sometimes they can even present the fractures very rarely. Okay.
Yes.
Sometimes a child is a breech presentation. Sometimes very, very rare. Okay, so it is a very severe form of biliary atresia where it has occurred in utero onset. But in general, it takes a longer time for vitamin D, vitamin A. No? However, vitamin K is very important. Okay, so it indicates which pathway is affected due to coagulopathy in your case. Extrinsic pathway. Vitamin K is the extrinsic pathway. Very good. Yeah, proceed. Dakshan, anything you want to add?
No, ma'am, I just wanted to ask,
Yeah.
what will be the initial manifestation of vitamin A deficiency? This child, you said no features, but if the child presents any child after the stores are depleted, what would be the initial sign of vitamin A deficiency and symptom?
Symptom.
And night blindness and conjunctival cirrhosis.
No, not night blindness. That is, you are getting WHO grading X and XF. The earliest symptom of vitamin A deficiency. What do you call that? The earliest sign and earliest symptom.
Symptom.
The earliest symptom is defective dark adaptation. Okay.
The child will be groping in the dark, will not be able to crawl, and the child will sit in a corner and will grope in the dark.
You should ask whether the child is playing during, when the other children are playing, the child will not play during evening. That is very important. Older children. And guttal pigmentation can be earliest sign of vitamin A deficiency. Then you read about the WHO. You know, X1A, X1B, X1, no, like corneal ulcers, more than 1/3, less than 1/3, X of excess, all those things. They'll ask you in the exam. Vitamin A deficiency. Okay, very good. Because vision is very important. If you miss the bus, the child will lose the vision. So it is like an emergency. Both your coagulopathy, vitamin A deficiency, as a pediatrician taking care of the child, give much importance to correct these vitamins. Very good. Now proceed.
You also know about the WHO staging of vitamin A deficiency, just in case. Okay.
Yeah.
Like you'll have to know. I'm just telling you.
It's very easy to remember. Okay, X1A, bite spot, X1B, conjunctival cirrhosis, then corneal cirrhosis, then 1/3, more than 1/3. XN is night blindness, XF is ophthalmic fundus, XS is corneal scarring. Okay, yeah, proceed. Next slide.
Chest appears normal, abdomen slightly distended, more in the upper quadrant, spine normal, limbs normal, palms and soles normal.
Spine, why did you say it is normal?
Ma'am, in Alagili syndrome, there can be spinal abnormalities.
So how best to diagnose Alagili syndrome? Can you get kyphoscoliosis? It's more of an extra radiological diagnosis. Okay, what you see on X-ray is called, what is it called?
Butterfly vertebrae and
what is butterfly vertebra?
Fusion.
It's not fusion. Failure of fusion of the anterior arch. Okay.
What will you look for in the chest?
In chest, signs of vitamin D deficiency, racket rosary, Harrison sulcus.
Very good. Okay,
you're not
so
seeing
the palms,
syphilis. Yeah.
anything to look for? The palms you've written, palms and soul normal. Though I mean, you said they were ectric. It's okay, but what will you look for in the palms?
Palms for Down syndrome, we can see for simian crease, single palm crease.
Sometimes you can palm or erythema in chronic, no, when they go for chronic liver disease also, and even your HLH, they can have palm or erythema. Okay, look for all your simian crease, dermatoglyphics, distally placed triradius, short and stubby fingers for Down syndrome, all those things you should know. Okay, very good, doctor. Proceed.
And stool examination, pale stools noted.
Yeah. Is it normal? Is it normal or abnormal?
Abnormal, ma'am.
Abnormal, yeah. Okay. Should I even collected the urine color in a white bottle to compare? Okay. For the other students to know that. Inspection, yeah, proceed.
Abdominal examination, starting with inspection. Abdomen looks distended more over the upper quadrant. All quadrants move equally with respiration. Flanks appear free. The skin over abdomen appears normal. There are no visible dilated veins or scars. Umbilicus is inverted. External genitalia is normal.
Umbilicus, anything else you look for?
Mm.
Umbilicus, we can see for like umbilicus hernia can be there.
Very good.
Hypothyroidism and
External genitalia, what will you look for?
external genitalia, we can look for micro penis or undescended testis in panhypopituitarism.
Anything? Sometimes there is, you get ascites. There is a
Yes,
biliary
ma'am.
ascites. There is cholestasis. What is the importance of a gentle examination case?
Color of the scrotum.
Where do you, what is the color?
Green.
Green scrotum indicates what? In the presence of your cholestasis with ascites, perforation of the bile duct.
Perforation of bile duct.
Okay, proceed.
Okay.
Coming to palpation, superficial palpation, abdomen was soft, no guarding, tenderness, warmth noted. On deep palpation, liver is palpable 4 cm below the right costal margin with a smooth surface and firm consistency with sharp border. And spleen was 2 cm palpable below the left costal margin along with the long axis and the surface was smooth and it was firm in consistency.
So why do you say what is the inference of your liver and spleen in a case? 4 centimeter liver is normal in a young infant.
What is the span of the liver? You've
liver
been palpable 4 centimeters.
Yes, ma'am. On percussion, liver span is 7 cm, ma'am.
Is it normal or increased?
It is increased, ma'am.
Yeah, one is it is increased. Number two, what is the important thing you noticed in your presentation? The previous slide. Liver is?
Go to the
Liver is?
Firm in consistency.
Firm in consistency indicates what? In children. Chronic liver disease. Okay. Yeah. So soft liver is okay and 2 centimeter just palpable liver is okay. But in your case, 4 centimeters, span of 7, firm in consistency always indicate it is a pathological one. And what is the inference of spleen in your case?
Spleen can be due to the portal hypertension, starting of portal hypertension.
So where will you get spleen early? Is it in biliary atresia or in your hepatitis you get a spleen, early spleen?
Hepatitis.
Yeah. So in biliary atresia, I think we can
have more than one spleen or malformed spleen or multiple spleen in a case of neonatal
very good.
cholestasis.
Yeah.
Yes, ma'am. Biliary atresia with splenic malformation, there can be polysplenia.
Or asplenia also, not only polysplenia, asplenia, anything. Suppose you are palpating, the liver is on the left, the spleen is on the right.
Cytosinosis.
You also look for cardiac also, no? Lateralization defect. Very good. Yeah. Next, yeah, proceed.
And the external genitalia, bilateral testis palpable. Coming to cardiovascular, S1, S2 heard, no murmurs were heard. Respiratory, normal vesicular breath sounds. CNS,
here again, the sounds, you should also talk about the apex because just now madam said there could be splenic malformation, multiple spleens or asplenia. It could be a heterotaxy. In that condition, what will you expect in the cardiac system?
Situs inversus.
Very good.
Apex can be seen on the right side.
They could be dextrocardia.
Okay,
sometimes, very good.
The apex.
Sometimes if it's a neonatal infections, IU infection, cholestasis, what is the importance of cardiac examination in a case?
Murmurs can be heard.
VSD murmur, rubella.
In PDA, rubella PDA, peripheral pulmonary stenosis.
Very good, peripheral pulmonary stenosis.
In allegedly we can get.
Allegedly peripheral pulmonary.
Okay. Any other infection you will get a cardiac lesion, common cause for neonatal cholestasis?
Rubella we can see, ma'am.
Very good. What will you get?
PDA murmur and continuous machinery like murmur
Right.
and again pulmonary stenosis murmur.
Very good. Next.
Coming to the summary, this is a 2 months old child, born as term baby with a normal birth weight and well thriving, presented with cholestasis, hepatosplenomegaly, without features of bleeding and signs of decompensation. I would like to think.
With firm
would-
hepatomegaly, with splenomegaly. Okay.
I would like to think in terms of neonatal cholestasis syndrome. My first TD will be biliary atresia and choledochal, then a PFIC, bile acid synthesis defect, and cystic fibrosis will also be there.
So just keep down on the
Do you
list.
still want to entertain the diagnosis of cystic fibrosis?
No, ma'am, because of liver and spleen.
Yes.
I'm thinking.
Vouch for your biliary
Because it is an
atresia.
apparently okay child,
Yes, ma'am.
and you said all the anthropometric measures were within range. Unlikely.
Yes, ma'am.
So still the first is always a biliary atresia. Okay. And choledochal cyst having a spleen. If it has gone for a chronic cholestasis, which has never been attended, then they go for secondary biliary cirrhosis. Even biliary atresia spleen appears late. Okay, whereas now you infections, neural hepatitis, you get spleen earlier. Okay, anyway. Oh, good. Proceed further.
Coming to the investigations part, I would like to do a complete blood count.
Yeah, 1 minute. How complete blood count is very essential. How can it help in your case?
In chronic diseases, there can be a mild anemia can be seen, ma'am.
Very good. Mild anemia, sometimes thrombocytopenia.
Thrombocytopenia,
Where we get
thrombocytosis.
thrombocytopenia?
In intrauterine infections, we can
Very
see
good.
thrombocytopenia.
Very good, very good. Anemia, thrombocytopenia. Suppose child is having a superadded infection.
Then WBC
Not
levels
around
can
this
be.
case. Look for your total count.
Hmm.
Shift to the left and hypersegmented neutrophils, toxic granules.
Toxic.
Okay. And count can be either increased or low. So sepsis. Okay, very good. Proceed further.
Then liver function test along with
What do you
GGT.
mean by
liver function test?
liver function test? It is
Yes, ma'am. SGOT, SGPT, and
no, before that, what will you see? Is it directly go for SGOT PT or would like to do a
no, ma'am. Bilirubin.
very good.
Bilirubin, I would like to see bilirubin.
You will want to fractionate.
Fractionate along with fractionate.
When you suspect cholestasis on LFT?
When the fractionated, when seeing on the fractionated, if the conjugated is more than 20%, I would like to think in terms of
the total bilirubin is only 4.
Then if it is more than 1 mg per deciliter, then I would think of cholestatic.
Very good. OTPT, will it give a clue? OTPT.
Usually in hepatocellular, it can be more highly elevated, but in obstructive cause and all, it will be
mild to moderate elevation.
Mild to moderate elevation.
What other tests will you do? SAP?
SAP and GGT I will do, ma'am.
No, SAP and GGT was say what happens biliary atresia and hepatocellular cholestasis.
In elevated, ma'am. It will be elevated in obstructive causes. GGT will be elevated in obstructive. Markedly elevated in obstructive causes now.
Cholestasis, very good. Then, whereas mild to moderate in hepatocellular cholestasis. Okay, very good. Yeah.
How does GGT help you?
Based on GGT, we can classify like high GGT and low GGT.
Very good. See, in cholestasis, you expect gamma G to be very high. Suppose not biliary atresia, apart from biliary atresia, how gamma GT will be very helpful in a case?
We can classify as high and low, ma'am. In low GGT, we should consider about PFIC, ma'am. Usually PFIC, apart from PFIC type 3, others will have a low GGT. And bile acid synthesis defect also will have low GGT.
Okay, what else?
So low.
Even endocrine causes will have low GGT, ma'am.
What are the other liver function tests that you will be doing?
Albumin.
Albumin indicates what?
Albumin indicates the chronicity, ma'am. If unsynthetic function.
The liver indicates chronicity. And
Yes,
PT
yes.
indicates more of a prognosticate marker for ALF, whatever it is. So both a prothrombin and albumin indicates a synthetic function. OTPT indicates what? Hepatocellular damage. Okay,
Damage.
very good. And your excretory function is assessed by the bilirubin.
Yes.
Very good. Yeah.
And electrolytes, glucose and creatinine I would like to do. And along with that, fasting USG abdomen I would like to
We
do now.
make the baby fast how many hours?
4 hours now.
So what would you like to see on ultrasound now?
And if there is in fasting, then normally the gallbladder should be distended, ma'am.
Yeah.
But here the gallbladder can be contracted or
So it
not
can be
even-
contracted or absent or atretic.
Yes, ma'am.
And what is pseudo GB sign or a ghost sign?
Ghost triad, there are 3 components of ghost triad, ma'am. The gallbladder length is less than 1.9 centimeter, and there are mucosal lining is not smooth, and intestic contour,
Very
if
good.
it is called
So
ghost
in the
triad.
region of the gallbladder fossa, if you see all these findings, you say GB, pseudo GB sign or a ghost sign. What is any other sign you know of in cholestatic jaundice?
Even triangular cord sign can be
Yeah.
used.
What does triangular cord sign?
It is a hyper-echogenic triangular shape, right? Hyper-echogenic.
No, it's not a triangular shape. It is a hyperechogenic foci. Where is it seen?
In the portal triangle, just above the bifurcation of the
It's not
portal.
above. It is anterior to the right branch of the portal vein. The portal vein bifurcates into right and left, anterior to the right branch. If you see a echogenic foci more than 4 millimeter in size, that indicates a remnant or a fibrotic bile duct which is not developed. That fibrotic remnant is seen as a echogenic foci. Okay, then you suspect the atresia. Very good.
Dr. Tarun, would you do a renal function test in this child? Would you want to do? I mean, apart from your creatinine that you have mentioned, why would you want to do a renal function test? Why would you want
In some cholestasis, there can be renal involvement also.
like what?
Like tyrosinemia and atherogryposis and renal dysfunction
Okay,
cholestasis.
hepatorenal tyrosinemia. Any other condition? Any other surgical cause? Polycystic
Caroli's disease.
So
okay, what other systems will you have involvement when you have Caroli's apart from your liver and the kidney? You can have a polycystic kidney.
Aneurysms in blood vessels in the brain.
Yeah.
CNS.
So ultrasound, when you said about the, like a triangular cord sign, a distant gallbladder, your pseudo GB sign, look for the liver echoes, look for what are the things you should see. Spleen you mentioned. Then look for any, ascites, minimal ascites. What are the other uses of ultrasound in cholestatic jaundice apart from biliary atresia? Polysplenia, look for asplenia, accessory spleen, IVC, and the cardiac situs inversus, whatever it is. On ultrasound, if you're able to pick up, apart as Dakshani said, your Caroli's disease, a cystic disease of the renal, or even a cyst of the liver can be picked up on ultrasound. Don't forget your gallstone. A gallstone can even block a CBD stone. Indirectly, it will be seen as a dilatation of the intrahepatic radicals. So when you have a gallstone with IHB, think there is one stone sitting in the distal CBD that you can diagnose. Any other thing? Choroidal cyst, the best test you can diagnose by a ultrasound. So look for the features of biliary atresia, complications of portal hypertension. Look for any veins, your periduodenal veins, your collaterals, advanced stage. Suppose the baby comes at 8 months. Look for all those things, even beyond. Any other signs of portal hypertension, look for other cause of cholestasis as well. Okay, so that is the role of your ultrasound. So always ask the ultrasoundologist, look for all these conditions, and it should be done on a 4 hours fasting of milk-free diet. Why milk-free diet is very important? Look for a gallbladder. Tarun?
After feeding, there will be contraction of the.
Why contraction of the gallbladder with the milk?
Why would you want to do it in fasting status?
Usually in fasting, gallbladder should be distended, ma'am.
No. Why? See, you can give even sugar water, but not milk. I'm asking why milk-free diet is very important. What happens after a fatty meal?
There will be
The
contraction.
gallbladder contracts. Due to release of dash. What?
Cholecystectomy.
Very good. Cholecystokinin by which organ?
Duodenum, ma'am.
So the release of the cholecystokinin after a fatty meal by the duodenal mucosa causes contraction of the gallbladder, which you can erroneously misinterpret as contracted gallbladder. That is the principle. Okay, very good.
And I would like to do proceed liver biopsy.
See, 1 minute. Suppose your child has got a persistent clay-colored stools, a background of dark urine with change of diaper with jaundice. At 60 days, would you like to wait or would you get a surgical opinion at this juncture?
No, ma'am.
I would like to give one shot of vitamin K and involve the surgeon at the earliest. Okay.
Yes.
Because you have to operate at the earliest. You can tell the simultaneously, you can ask the surgeon to have a look, and suppose liver biopsy is the best gold standard. What are the fallacies and how liver biopsy is very useful?
In liver biopsy, in biliary atresia, it can show bile duct proliferation, ma'am.
I will differentiate liver biopsy finding between a neonatal hepatitis versus a biliary atresia.
In biliary atresia, usually there will be bile duct proliferation.
Where the changes will be more in the biliary atresia. It is more in the periportal region. Whereas in neonatal hepatitis, mainly it is a panlobular. Okay. So here the portal tract will be expanded. The changes are more in the periporta. Then you get ductal proliferation, bile legs. Then you think of biliary atresia. Whereas you get giant cell formation with after damage, panlobular changes, you think more of a neonatal hepatitis. If the surgeon is able to do an intraoperative cholangiogram, he can combine with the liver biopsy. Okay. Otherwise, you have to do a liver biopsy. But what is the prerequisite? You need to have a very experienced pathologist who is well trained in identification of these, biliary atresia.
Yes.
Pathologist who is well trained in pediatric liver histological, who is got a very good experience. What is the other use of liver biopsy? What is the mimicus of biliary atresia? Suppose you are doing a liver biopsy. There are few conditions which can mimic biliary atresia in histology. Even cystic fibrosis, TPN related cholestasis can mimic changes of biliary, like biliary atresia. But when all the other corroborative evidence like absent gallbladder, always you think biliary atresia, then you should tell the pathologist look into all the features of biliary atresia. Okay. And intraoperative cholangiogram. Very good. Which is the gold standard to diagnose biliary atresia?
Intraoperative cholangiogram.
Combined with liver biopsy. If you are not doing a liver biopsy, tell them to go for a POC with liver biopsy. Okay. Very good. Suppose a liver biopsy gives a clue of biliary atresia. You straight away hand the case to the surgeon to proceed with Kasai. Okay. Because there is no ascites at this juncture. Suppose a child comes at end-stage liver disease with ascites, severe bleeding, encephalopathy, then that is a child, the transplant center, they can take up. Otherwise, we have to we can go as a bridge with Kasai, then proceed with, okay. But end-stage liver disease is always a better candidate for liver transplant. Okay. What is the other use of liver biopsy? One is picked up. Very good. What will you see on infections in liver biopsy? Suppose you're doing.
In intrahepatic infections, we can see inclusions, ma'am, like CMV.
In Paula inclusions in CM infections.
We can see.
So allegedly can be picked up. Is liver biopsy the best for your neonatal lines for disease in this child? Suppose you are suspecting. No, because in young infants, hepatology liver cells will contain iron. So you have to go for an extra hepatic liver, extra hepatic tissues for a iron content, like a buccal mucosa. Okay. Is it clear for you, Dr. Tarun?
Yes,
yeah. So then, what simple urine examination can I give a clue? Suppose you are in a simple
biopsy finding.
Sorry, ma'am.
What is the biopsy finding in the case?
Dr. Tarun?
Yes, ma'am.
Ma'am, learning again.
Liver biopsy, was it done in your child?
Ma'am, not yet, ma'am.
So suppose liver biopsy is done, I think I mentioned, you look for the changes at the porta. portal tract expansion, look for bile ducts, bile infarct, and ductal proliferation. Okay. To diagnose biliary atresia, look for any other conditions. Suppose if it is not biliary atresia. And suppose I ask you, you are in a primary health center where you have a small lab by the side. Which simple urine examination can give a clue between obstructive versus non-obstructive cholestasis? In cholestasis, if you do a bile salt, bile pigment, will it be positive or negative?
Cholestasis, it will be negative, ma'am.
Negative. Oh,
Positive.
positive. No,
Positive because of
BP will be positive. That's why you're getting the stain in the diaper because it is a water soluble. Okay. And it is positive both in hepatocellular as well as obstructive cholestasis. But one thing you can differentiate between obstructive and non-obstructive by a simple urine exam, urobilinogen. Urobilinogen will be absent in
urobilinogen.
in
Obstructive causes, there will be no bile flowing through, ma'am. So it will be
absent. It will be present, but the quantity may be less.
Less.
Okay, so simple. So BSBP will always be positive, whether it is intrahepatic or it is an extrahepatic, whatever is obstructive cholestasis. So simple, basic thing you should never forget. Okay. And suppose we don't advise HIDA. What is the role of HIDA? What is your idea on HIDA scintigraphy?
Here, since it is a persistent pale color stool,
so would you like to have HIDA here?
No, ma'am. Here we are not planning to do.
I will not do HIDA. Very good. I will not do HIDA because it is in front of your eyes. There is no bile into the intestine. The stool is white in color. Don't do HIDA. Suppose yellow in color. Will you like to do HIDA?
Yes, ma'am.
Yes. Please revise your statement. When the stool is pigmented, what does it indicate?
If it is pigmented, then there is a bile flow, ma'am. So again,
would you like to do HIDA then?
No, ma'am. Only when there is a doubtful
pale yellow stools.
Yes, ma'am.
Pale yellow stools, when are not able to differentiate, suppose you don't have any other MRCP, whatever it is, you can go for HIDA scintigraphy. Otherwise, not routinely recommended. And what precautions? I'm just completing for as the sake of the, like for this case. What is the importance of doing HIDA? As you said, it's only in doubtful case of pale yellow stools. Number two, what precautions you advise before doing HIDA scintigraphy?
Yes, ma'am. It will unnecessarily delay the diagnosis also. Like
delay. Yeah. Suppose child comes at 20 days, you have a time, but not only when you have doubt. Number two, you have to prime with?
Priming with either phenobarbital or
what is the idea behind doing priming with the drugs?
It acts as UDCA. It acts as a cholinergic and increases the production of bile.
One thing.
What facilitates what? Which is bile salt dependent and which is bile salt independent? Which increases?
Bile salts independent.
Which increases bile salt dependent flow and which increases bile salt independent bile flow?
Udka increases bile salt independent, no?
Dependent. That itself is a bile salt or a bile acid, right?
So why should you prime? See, you have to analyze two things when you're doing HIDA scintigraphy. One, you have to take look for the liver uptake or the hepatic uptake. Number two, what are you going to look?
Excretion.
Excretion into where? Excretion into the intestine.
Intestine.
Two counterparts you have to look. In neural hepatitis, uptake will be?
Uptake will be less, ma'am.
Yeah, defective, but excretion will be there. In biliary atresia?
Biliary atresia, uptake will be good, ma'am, but excretion will not be there.
Yeah, even after, in delayed images after 24 hours also there will not be any excretion. But when there is severe cholestasis due to intrahepatic cause, even if there is no blockage, bile duct is patent, there will not be any flow. Okay, so it's for that only you are priming your children water neonate with your UDC and phenobarbital to increase the uptake. Can you understand, Tarun, what I'm telling?
Yes, ma'am. Yes,
severe intrahepatic cholestasis, even if the bile duct is patent, there will not be flow into the intestine. So you have to increase the uptake. Okay, so look for the intestinal area. In pale yellow, only you do that too when you have a time. Okay, then you prime and do. Otherwise, no need to. No, routinely HIDA is not indicated. More so, don't do HIDA for a white colored stools and for a pigmented or a greenish or yellow stools. Okay, very important. What is when you're doing endoscopy?
I don't think liver biopsy help in any other cause.
Like lysosomal disorders like Niemann-Pick, we can see inclusions in organelle.
Niemann-Pick, would you go for that?
Okay,
No.
storage disorders like gauches.
So usually you go for a now with the advent of genetics, no, we prefer genetics. You do a bone marrow, no, then because at coagulopathy always, no, we should be very cautious. Will bone marrow give a clue? Where, see, the spleen will be big in a case if it is a lysosomal LS, whatever it is, Niemann-Pick or a lipid storage disorders. More than this liver, spleen will be more. Okay.
In alpha-1 antitrypsin deficiency,
there will be PAs positive dash test resistant.
Yeah. And you have to look at the electron microscope. Okay.
Yes.
So genetic in certain selected cases where you have a genetic analysis, you can proceed. Suppose child has a big spleen, anemia, think of lipid storage, go for a bone marrow. And what will you get on a bone marrow if it is Niemann-Pick disease? You get a foamy histiocytes. And for a Gaucher's, Tarun?
Lipid, gorgeous.
Gaucher's, you get a crumpled silver paper appearance. Okay, these are the few clues. Then you proceed with your genetic analysis. Okay, whatever it is. Okay, how are you going to manage now? Is the time over so much, Dr. Prasanna? Are we exceeding the time?
No, madam, we'll finish, madam, in 15 minutes.
So the nutrient, how are you going to manage, take care of the nutrition? So breast milk contains your emulsified fat. Then treatment of your
here we have to
cholerytics, read about all your cholerytic agents. Then vitamin supplementation, ADEK. Then
MCT oil can be used.
But MCT oil, the child is more than 6 months, you want to give other, okay, MCT oil. Otherwise, a breast milk contain pre-emulsified fat. Then double the dose of your.
Also give water soluble vitamins also.
Double the dose of water.
Double the dose of your vitamin B complex. Okay, then trace elements, calcium, phosphorus, zinc. So these are nutrition, breast milk, vitamin supplementation, different cholerytic agents. Suppose what are the complications of your then specific therapy? This is child with biliary atresia means you have to hand over the case to a surgeon. Suppose it is your metabolic liver disease, those options like tyrosinemia. What is the screening test for tyrosinemia?
Urine succinylase.
That is a confirmatory screening test. Blood.
Screening?
Alpha fetoprotein be very high, sky high level of alpha fetoprotein.
Alpha fetoprotein.
Succinyl acetone. Okay. Then for hypothyroid, you mentioned sepsis, you have to do always a sepsis screening, both urine, blood culture, and urine examination, suspecting your metabolic, do a Benedict test for a galactosemia, all those things. So what are the complications of a cholestatic jaundice? Suppose long-standing cholestasis, what are the complications they go for?
They go for
they
can go for fibrosis, cirrhosis of the liver.
So you just classify. Say what happens in cholestasis? No, the substances that are normally excreted in bile are retained in the blood. Okay. So you get jaundice, you get cave-ring. They've got non-Wilsonian cave-ring due to chronic cholestasis. Then due to bile salt, you get itching, pruritus. Then abnormal protein synthesis. Lipoprotein X can be there. Xanthomas, xanthelismas. So classify like that. Number 2, the substances, they are not absorbed due to cholestasis, like malabsorption or fat, ADK deficiency. They can go for vitamin A deficiency features, D deficiency, E and K. And rickety bone changes, they can have short stature, malnutrition, malabsorption. Third, due to long-standing cholestasis, they go for biliary cirrhosis, secondary biliary cirrhosis. They can have splenomegaly, ascites, portal hypertension, varicose bleed. Okay, then encephalopathy. So classify like that. Okay, substances normally external bile are retained in the blood. The consequences, then malabsorption, vitamin deficiencies, short stature, then go for ascites and complication of portal hypertension. Okay, you should remember like that as a easy way of remembering things in clinical practice. So specific therapy available for your tyrosinemia, hypothyroid, sepsis. Then any other conditions? Specific therapy? Cytomegaloviral infections?
Yes, ma'am. We can use Gansicor
Only
virus.
confirm the diagnosis. Suppose
No.
liver biopsy are not doing any other way of
CMV
doing it.
infection.
CMV, IgM, we can some urine, we can test for in
Urine
urine.
should be more, no, for anyone.
Yes,
The
ma'am.
level should be very high, blood PCR. Okay. And you can even do a DNA, CMA DNA extraction also. Okay.
Any
So,
other torch infection you can treat?
yeah.
You have a specific treatment for any torch
Toxoplasmosis,
infection
Yeah,
apart
what
from
drug? What drug?
sulfadiazine.
Trimethoprim sulfadiazine combination. Okay. Suppose I ask as a, like a pediatrician, what is the role of an X-ray in cholestasis?
X-ray can show defects of vitamin D deficiency. It can show, ma'am, like rickets. It can helpful
Very good.
in
Okay.
rickets. And Alagili syndrome, to rule out
Very
Alagili
good.
syndrome
Likely over. Very good. Number two.
can be
Then
useful.
then sometimes you can get what is celery stalk sign?
Sorry.
Alternate hypo and hyperuricin bands seen in rubella. Okay, then sometimes congenital syphilis, you can have a moth-eaten appearance of the middle end of the tibia. Very good. Then suppose you are taking X-ray skull.
Yes, ma'am.
You can get no intersutural bones, Bowman bones in Down syndrome. Okay. On calcification, periventricular calcification in cytomegalovirus.
Toxoplasmosis. We can give chorioretinitis.
Classification. You just remember like this: PVC,
Yes, ma'am.
PVC, no, periventricular cytomegalo, DT, diffuse toxoplasmosis. I think it's easy to remember.
in toxoplasmosis, congenital toxoplasmosis, what else can you see? I mean, what is the triad of congenital toxoplasmosis?
Chorioretinitis, hydrocephalus, and intracranial calcification.
Very good.
Yeah.
So I think specific therapy and always put supportive care. Okay, whatever I said, no, like nutrition, vitamins, supportive therapy, treatment of complications of ascites, coagulopathy, encephalopathy, and associated infections. And suppose treatable conditions you have to treat. If it's a metabolic disorders, you have to prove and you have to do what?
Genetic testing.
Genetic testing, counseling the parents.
Mm.
They'll ask what is the risk of recurrence in other sibling. Should counsel them. What's the prognosis? Okay. What is the drug for your nutrition you have written? Okay. So operable conditions, you have to hand over the case to surgeon. This child has come at 60 days. You can't wait too much. Always the clay colored stools, give one shot of vitamin K, do the LFT and call the surgeons. Go for a POC and liver biopsy, or if you do a liver biopsy, tell them to take over the case and do at the earliest Kasai. And have a regular follow-up. What is the natural history of Kasai surgery in a child with biliary atresia?
1/3 will do well, ma'am.
Very
Third will have a later complication. Will need for liver transplant later. 1/3 can go into failed Kasai.
Failed Kasai, they may even succumb if not attended earlier. Okay, so that is the thing. So liver transplant. So the liver transplant prognosis depends on what are the factors because you are in a transplant center.
INR.
Yeah, one is the age of the child. Number two.
INR levels, ma'am.
Number two is nutrition of the child.
Nutrition.
Number three, associated malformations can have a very big prognosis. Suppose child has got a cardiac problem. Child has got some aneurysm within the brain. Child has got a renal problem. No.
Yes.
Yeah, associated anomalies can also have a role in the prognosticating marker in these children. So constant supportive care is very important. Any other thing you would like to show? Each and every investigation has got a value. You just divide the LFT, you classify and look for the differentiate between whether it is ectocellular or biliary atresia, whatever it is. Then when the child has a age reverse indicate chronic liver disease, child has gone in for a cirrhosis. Okay. Anything?
Dakshani, any questions?
Dr. Tarun, how would we avoid such delayed diagnosis of cholestasis? Because this child has come at the day 6.
Very good question, Dakshani. Proceed. Yeah. How best to diagnose?
How best or how?
Like we can give stool charts in
Very good, Tarun.
vaccination
Start,
thing.
and IAP has come out one more test. What is the test card?
What is the card?
Urine color card and stool.
Yeah. Stool color card was devised by whom? Which country?
Taiwan or Japan.
Very good, Taiwan.
Very good. Yeah.
So you can use this Taiwan stool color along with the urine color. You tell the mother to come at 14 days with a stool color, okay, and the urine color. When they come for immunization also, you just examine the baby, look for any jaundice, so ask the mother whether urine colors is stains the diaper. The next question you should focus on which, after urine color, what is the next question you should ask the mother?
Next is stool, ma'am.
Very good. Stool, you should tell whether it is clay, white, chalky white, or yellow, or green, or pale yellow. If it is clay, what adjective you should ask the mother? Next question. Whether it is persistently
pale or intermittent.
Very good. Very good. Very good. Okay. So any doubt?
So you attach this card with the discharge summary. Now you ask them to monitor.
Sure.
So awareness is very important. Whoever is a primary care or even the parents, they should know that color of the urine is not due to vitamins. The color of the white color stool is not due to breast milk or artificial formula. Okay. And any child with high colored urine, change the diaper, they should be referred to the primary care physician, the pediatrician, where they should identify the problem at the earliest and proceed accordingly, whether it is surgical or medical, whatever it is. Why MCT oil? What is the natural source of MCT oil?
Coconut oil is a very good source of MCT
What is the
oil.
disadvantage of MCT oil? If you are going to give only MCT oil, they'll go for essential fatty acid deficiency. That's why you always give groundnut oil also. Okay. And my MCT oil, what is the advantage?
Ma'am, it is directly absorbed from the portal vein, ma'am.
It does not require bile salt. Yeah, it does not require bile salt activated lipase for absorption. It enters with circulation directly.
Portal circulation.
Yeah, unlike your fat, which requires enters the circulation as chylomicrons. Very good. Any doubt?
Anybody wants to ask anything can put it in the chat box. I think we enjoyed a very good session, madam, actually. From two great classical teachers. I think we call them classical.
Thank you. I think we have done our job. Probably, I think will be useful for the PGs.
Yes, madam. This is being recorded in YouTube, and many people are following it, and there are a lot of views they see again and again for the exams. So I think this will be very useful for the exam going PGs. Thank you, madam. Thank you, Dr.
Thank you.
Thank you, sir. Thank you so much.
And Dr. Tarun, you did very well.
Yeah.
Tarun, yeah.
80% of the questions that.
Yeah, he's more than 80. He has answered almost 90. And he's very calm, quiet, and polite.
Very calm.
Yeah, very. That is very important.
Worked up at all.
So if at all the same case comes in the DNB exam, then you'll be on course for a medal. So I think you should do well in your exams.
Yeah. For the want of time, I will not mention about the cholinergic agents because I think time is over. Read about the drugs like UDCA, phenobarbital, rifampicin, what are the other antihistamines, steroids, how we are now, like even ondansetron can be given for pruritus, and opioid and like naltrexone, almifene, if nothing is working, plasmapheresis, ultimately liver transplant. But you should tell the mother especially not to bathe with a very cold or very hot water, lukewarm water, no? Because when they have intense itching, they should always wear a cotton clothing. They should cut the nails. When the babies have got no nails, they even get scratching. And chronic cholestasis, they can have hyperpigmented skin or the knuckles, dark skin with shiny nails. So, and examination, chronic cholestasis, apart from this, always look for the nails, the color changes, and any other things. Okay. So read about thing. Very good. Thank you, Dr. Prasanna, Dr. Somasundaram, Dr. Dakshayani, all the dear
Thank you,
students.
ma'am.
So,
Probably, I think after a long time, I'm also taking class for the being, yeah.
Om Sundaram sir has left for another meeting, madam. He said,
Yeah. Thank you, Prasanna. Just convey my message to him.
Thank you so much, sir. Thank you, Prasanna, sir. Thank you, Som, sir.
Thank
Ma'am,
you.
thank you so much.
Thank you, Dakshayani, for being with me.
Thank you,
My
ma'am.
pleasure,
Thank you,
ma'am.
sir.
Thank you for all the viewers who have joined and patiently waited. At least at the maximum, there are 50 online, and some of them have joined in YouTube also. So thank you all the viewers, and I hope you had a very good learning experience today. Thank you, madam. Thank you.
Thank you, Dr.
Ending the meeting for all. Thank you.